Hello everyone, my name is Narjess, Molecular Imaging and Theranostics Fellow at Peter MacCallum Cancer Center. Before everything, I would like to thank the organizing committee for giving us this opportunity to present our research work. Our research work is a systematic review and meta-analysis assessing the value of immunopet in lymphoma. And our immunopet is certainly not this one. But what is the definition of immunotherapy? Immunotherapy refers to any therapy that manipulates the immune system. This treatment modality has completely changed treatment strategies of lymphoid malignancies. In 1997, the introduction of anti-CD20 monoclonal antibodies such as rituximab, and then in 2017, the introduction of immune checkpoint inhibitors such as anti-PD-1 and anti-CTLA-4 have completely changed lymphoma management. And just recently, CAR T-cell therapy appears to be the next promising step in lymphoma management. Because of the inherent property of Hodgkin lymphoma and most subtypes of non-Hodgkin lymphoma as highly FDG-heavy tumors, FDG PET-CT imaging is a response assessment tool for these diseases and have a non-replaceable role in non-invasive response monitoring. By now, different visual PET criteria has introduced for response assessment, and more recently, following the introduction of immune checkpoint inhibitors, some modified response assessment criteria were added. Here, we will review the role of FDG PET imaging in response assessment and outcome prediction in the lymphoid tumors treated with immunotherapy. Performing FDG PET in lymphoma patients, the clinicians are interested to know which parameter can better predict the outcome. Is it patient's initial staging, quantitative and semi-quantitative parameters such as SUV max, metabolic tumor volume, and total lesion glycolysis, or different visual criteria such as dual score? We searched PubMed Medline database for all related published data until March 2021. No language restriction was applied. References of eligible studies were scrolled as well. Studies were eligible for full-text assessment if they were clinical studies on lymphoma treated with anti-CD20 immune checkpoint inhibitors or CAR-T with incorporation of FDG PET-CT for response assessment. The main four exclusion criteria were treatment with radioimmunotherapy, possibility for incomplete or duplicated results, CNS lymphoma, and HIV-related lymphoma. The quality of all eligible articles was evaluated by employing the established critical appraisal tool obtained from the Oxford Centre for Evidence-Based Medicine. This tool is designed to evaluate the quality of the prognostic studies by taking into account several factors consisting of patients' registration time, follow-up, duration, outcome criteria, and adjustments for important prognostic factors. For metabolic baseline parameters, we considered tumor burden indices, including metabolic tumor volume and total lesion glycolysis, as well as tumor metabolism indices, including SUV max. For the response assessment, we considered visual methods, including double score and change in SUV max as a semi-quantitative parameter. This Prisma flowchart shows our research approach. As seen here, the search yielded 1,488 records, with 21 additional records found from other sources. Of these, total records included 167 were duplicates. From the non-duplicated records, majority were excluded due to a variety of reasons. Of the remaining 228 articles, 137 were further excluded after full-text assessment, The main reason for exclusion at this stage was the unavailability of the PET data. Finally, 91 studies were included in our systematic review, of which 48 were included in the meta-analysis. Now I would like to draw your attention to the results. The main bulk of literature was about anti-CD20 therapy, encompassing 77 articles out of all 91 eligible studies. In the following slides, I'm going to very briefly talk about the results of pooled estimates from these studies, classified to baseline, interim, end of treatment PET, and studies used for prediction of either progression-free survival or overall survival. As seen here, for baseline PET, the best prognostic parameter was metabolic tumor volume for prediction of progression-free survival with hazard ratio of 3.19. However, the prognostic value of baseline SUV max was suboptimal with non-significant hazard ratio. Likewise, our results favored baseline MTV as the best prognostic marker for prediction of overall survival. For interim response assessment, a total of 38 articles investigated response assessment via early FDG PET-CT imaging after anti-CD20 immunotherapy, and of these, 19 studies were included in the meta-analysis. The subgroup meta-analysis performed for interim PET scan showed the highest hazard ratio belonged to the change in SUV max for prediction of progression-free survival. However, for prediction of overall survival, Dover score was the best prognostic parameter in the interim PET studies. For assessing the value of end-of-treatment FDG PET in risk stratification, 16 articles were eligible for meta-analysis. Interestingly, using end-of-treatment PET, Dover score was the best predictor of outcome, and for both PFS and OS, Dover score was better than IHP criteria. Here I have summarized the best parameters for prediction of the desired outcome. As seen on the screen, on baseline PET, metabolic tumor volume was the best parameter for prediction of both progression-free and overall survival. On interim PET, change in SUV max predicts PFS better than other parameters, while Dover score is the best assessment tool for overall survival prediction. And finally, on end of treatment PET, Dover score is the best criteria for prediction of both PFS and OS. In other words, the best predictor of PFS is Dover score on end of treatment PET and metabolic tumor volume on baseline FDG PET. For ICI and CAR-T, the number of studies were insufficient, and their methodology and population were quite heterogeneous for performing a meta-analysis. Therefore, we could not draw conclusions based on the current available evidences. The heterogeneity of the studies, including different range of age, clinical stages, and disease subtypes of the studies population, and different software and approaches was the main limitation of our current study. Many reports suggest that response assessment via quantitative methods in lymphoma patients provides better outcome discriminators than the visual criteria, regardless of the considered background reference tissue. Our findings show that for early response assessment following anti-CD20 treatment, the pooled hazard ratio of change in SUV max is higher than visual criteria for PFS, while for prediction of OS, the pooled hazard ratio of change in SUV max was lower than Dover score. On the other hand, superiority of Dover score over IHP criteria is supported by the findings of the current review. This is possibly due to conservative nature of the IHP criteria, which uses the mediastinal blood pool activity as the reference, while the Dover score criteria uses the liver parenchymal uptake as the reference standard. In conclusion, Our present study revealed that for anti-CD20 therapy, baseline MTV has the highest hazard ratio for both PFS and overall survival, and SUV max on baseline scan is not predictor of outcome. For interim response assessment, change in SUV max is the best predictor of outcome post-immunotherapy. And finally, Deauville score has the higher hazard ratio for PFS and OS compared to the International Harmonization Project criteria. I would like to express my deep appreciation and gratitude to Professor Andrew Scott for supervising this project, and it's a great pleasure to announce that this research work has just been accepted for publication in European Journal of Nuclear Medicine. Thank you for your attention.